In this video, we are going to discuss the acute cholecystitis. In this video, we are going to discuss the anatomy of the gallbladder, the clinical presentation of acute cholecystitis, the investigation and the differential diagnosis and the management of acute cholecystitis. Now come to the anatomy of the gallbladder. The gallbladder lies at the liver incisura at the junction of the right and the left lobe of the liver. It's a pear-shaped structure that is 7.5 cm to 12 cm long, having a capacity of 25 to 30 ml. It consists of fundus, body and the neck, and the neck terminates into a narrow infundibulum. The mucous membrane contains the indentation that sinks into the muscular coat known as crypts of Lashka. Now come to the anatomy of the cystic duct. Cystic duct is 3 cm long. Lumen is 1 to 3 mm in the diameter. The mucosa of cystic duct arranged in a spiral folds the valves of the Heaster. The walls surrounded by the sphincteric structures known as the valves of the Litkins, and the cystic duct joins the supraduodenal segment of the common hepatic duct to form a common bile duct. So the common hepatic duct is a 2.5 cm long that is formed by the right and the left hepatic duct. Now come to the anatomy of the common bile duct. The common bile duct is 7.5 cm long and formed by the union of the cystic duct and the common hepatic duct. It has a four part. The supraduodenal portion that is about a 2.5 cm long runs in the free edge of the lesser omentum, the retroduodenal portion, the infraduodenal portion and the intraduodenal portion. The intraduodenal portion that is opened on the summit of the ampulla of Vater and is surrounded by the sphincter of Oddi. So here is the picture showing the anatomy. As you can see, the common hepatic artery is dividing into left and the left hepatic artery and the right hepatic artery, as well as there is a cystic artery which is arising from the right hepatic artery, and the right and the left hepatic duct join to form a common hepatic duct, and the common hepatic duct joined with cystic duct to form a common bile duct, as well as there is a accessory artery which is arising from the gastroduodenal artery. There is another artery, retroduodenal artery. As you already saw in the picture, the arterial supply of gallbladder. So the cystic artery is the branch of the right hepatic artery which usually arises behind the common hepatic duct in 80% of cases, but in 20% of cases usually arises in the front of common hepatic duct. The accessory cystic artery, which is rarely present, but it arises from the gastroduodenal artery. So the lymphatics of gallbladder is very easy. It's simply drain into the cystic lymph nodes. What is Scallett's triangle or hepatobiliary triangle? It's very important in surgical point of view. It consists of three borders. The superior border is formed by the inferior surface of liver. The lateral is formed by the cystic duct, and the medial border is formed by the common hepatic duct. So first one picture is showing the normal Scallett's triangle, in which the lateral border is formed by the cystic duct, the medial border is formed by the common hepatic duct, and the superior border formed by the inferior surface of the liver. The second picture is showing the tortuous common hepatic artery, and the third picture showing the tortuous right hepatic artery. What is acute cholecystitis? Acute cholecystitis is simply the inflammation of the gallbladder that occur due to the occlusion of the cystic duct or impaired emptying of the gallbladder. This picture is showing the difference between the cholecystitis, cholelithiasis, choledocholithiasis and the cholangitis. When the stone is simply present in the lumen of the gallbladder is known as the cholelithiasis. When the stone is stuck in the cystic duct and it causes the inflammation of the gallbladder, that is the cholecystitis. And when the stone is present in the common bile duct, it is known as the choledocholithiasis. And when the stone is present in the common bile duct plus there is a biliary infection, this is known as the cholangitis. This chart is showing the differences between the cholelithiasis, cholecystitis, choledocholithiasis and the cholangitis. Causes of acute cholecystitis: the gallstones, the tumor, the bile duct blockage or the infection. There are three types of gallstones: the pigmented one, the gallstones based stones and the mixed ones. Now come to the clinical presentation of acute cholecystitis. The patient presents with pain in the right upper quadrant and sometimes pain radiating to the shoulder and the scapula. Initially, pain is colicky in nature, and the latter it becomes the constant and dull in character. Initially, it's sharp in character. It's also associated with the nausea, vomiting, fever, bloating, and it has also association with the intake of greasy and spicy food. Physical examination reveals the fever, tachycardia, the tenderness in the right upper quadrant, and the positive Murphy's sign. The patient with the suspected cholecystitis, we have to do the various investigation, which includes the CBC, which will reveal the leukocytosis. ALT and AST levels may be also elevated in cholecystitis or with the common bile duct obstruction. Bilirubin will be raised in the CBD obstruction. Amylase and lipase it is used to assess the acute pancreatitis secondary to cholelithiasis, but amylase may be also mildly elevated in the cholecystitis. Alkaline phosphatase may be elevated in the patient with the obstruction. Urine analysis is used to rule out the pyelonephritis or the renal calculi. We can also carry out the plain x-rays of the abdomen, and in the acute cholecystitis associated with the cholelithiasis, the x-rays will show the Mercedes Benz and the seagull sign. It also shows the calcification of the gallbladder, which is known as the porcelain gallbladder. It is the sign of the malignancy. The patient with the cholelithiasis associated with the cholecystitis, ultrasound will reveal the gallbladder wall thickening greater than 3 millimeter, wall edema, the gallbladder distension greater than 40 millimeter, the positive sonographic Murphy sign, pericholecystic and the perihepatic fluid. In the patient of acute cholecystitis, hydrous skin can also be carried out. In this scan, the tactinium labeled dye is injected and it's taken by the retroendothelial cells of the liver and excreted into the bile. It allows the visualization of the biliary tree and the gallbladder. 90% of the normal individual, the gallbladder is visualized within 30 minutes following the injection, with 100% being seen within the 1 hour. But if the gallbladder cannot be visualized, it is suggestive of acute cholecystitis. Findings of CT scans in acute cholecystitis, it will reveal the wall thickening, the pericholecystic stranding, the distension of the gallbladder, the high attenuation bile, pericholecystic fluid, and the subserosal oedema. There are two indications of CT scan in acute cholecystitis: when there is a diagnostic dilemma to rule out the cause of the cholecystitis, or when there is a suspected complications. So here is the image of CT scan, which is showing the pericholecystic abscess through the upper arrow and the calculi and the neck of the gallbladder through dotted arrow. This image is showing the perforated collapsed gallbladder, which is surrounded by the large abscess. These images are showing the hepatic abscess secondary to the GB perforation. These images are showing the bilioenteric fistula, which is formed by the perforation of the gallbladder into the duodenal bulb. These coronal images of CT scan showing the cholecystoclonic fistula, means fistulous tract between the gallbladder and the transverse colon. So why we have to do the MRCP in the patient of acute cholecystitis? Basically, it is used to identify the congenital anomalies of the cystic and the hepatic duct, post-surgical biliary anatomy and the complication, the pancreas divisum, anomalies of the pancreatic biliary junction, choledocholithiasis, biliary structure, chronic pancreatitis, the pancreatic cystic lesion, the biliary or the pancreatic trauma. What is the role of ERCP? ERCP is the therapeutic and the diagnostic. It gives the excellent images of the ductal anatomy. It is used to identify the cause of obstruction, that is calculi or the malignant structures. It also allows the stone removal and the stent placement. The differentials of right upper quadrant pain include the acute gastritis, acute mesenteric ischemia, acute pyelonephritis, appendicitis, biliary colic, cholangiocarcinoma, cholangitis, gallbladder mucocele, the gallbladder tumor, the gallstone, the liver abscess, and the peptic ulcer disease. Now come to the management of acute cholecystitis. Keep the patient NPO, replace the fluids, analgesics, administration of antibiotics, especially against the gram-negative aerobes, that is cefazolin, cefuroxime, and the ciprofloxacin. Ultrasonography is performed to confirm the diagnosis. If the jaundice is present, the MRCP is performed. The presence of the complication, you have to perform the CT scan, and the cholecystectomy may be performed on the next available list, or the patient may be allowed to return home when the inflammation has been resolved and it has been performed after the 6 weeks. So here is the Tokyo guidelines for the grading the severity of acute cholecystitis. The grade 1 is the mild acute cholecystitis, in which there is no grade 2 or grade 3 criteria of acute cholecystitis. A healthy person with no organ dysfunction or mild inflammatory changes in the gallbladder, making the cholecystectomy a safe and low risk operative procedure. The grade 2, that is a moderate acute cholecystitis, associated with one of the criteria like elevated white blood cell count greater than 18,000, the palpable tender mass in the right upper quadrant, duration of complaint is greater than 72 hours, and the marked local inflammation, that is gangrenous cholecystitis, pericholecystic abscess, hepatic abscess, biliary peritonitis, emphysematous cholecystitis. So the grade 3 or the severe acute cholecystitis is associated with dysfunction of any of the one organ, the cardiovascular dysfunction in which the hypertension requiring the treatment with the dopamine, or the neurological dysfunction, decreased level of consciousness, respiratory dysfunction, the renal dysfunction, which includes the oliguria and the creatinine greater than 2, hepatic dysfunction, and in which the PTINR is greater than 1.5, and the hematological dysfunction in which the platelet count is less than 1 lakh.